So here we're going to talk about the psychotic disorders, and I'm going to again first start with some major changes that came up in the DSM-5. I say major changes because these are probably the most important changes that came up. There are other changes, but these are going to be the ones that I want you to know about. So once again, we really didn't make any changes to the criteria for most of these. There are some. There are some very technical changes to the diagnostic criteria for schizophrenia, and that's kind of a big deal because schizophrenia is like one of our major disorders in the DSM-5. It's something that we diagnose frequently, and it's sort of your paradigm, one of your paradigm disorders, along with major depression and generalized anxiety disorder that you see, sort of our old bulwarks in the DSM. There have been some very, very, very technical changes, but I am not going to belabor these and talk about these here. If you want to pick up a copy of the DSM-5, you can read into it. But if I talked about these changes, I would only confuse you for the test. For the test, there are not going to be any changes you're expected to know at all for schizophrenia and its diagnosis. This is great news. We have eliminated the schizophrenia subtypes. Psychiatrists have been calling for this for a long time, probably except for the very, very old ones, but we have eliminated the subtypes for schizophrenia. Now, that having been said, I'm still going to include these in this lecture because on a practical basis, your attendings will probably expect you to know this, even though technically we don't use this anymore now. Your attendings will probably still like you to know some of these subtypes of schizophrenia, but be aware that they will not be on the test now. So these subtypes, like paranoid schizophrenia, which we consider to make up the majority of schizophrenia cases, disorganized, catatonic, which is then undifferentiated and residual. So I'm gonna talk about these, spend a little bit of time talking about what these were and the fact that we had these subtypes, and like I said, just because your attendings will probably ask you about them, I didn't want to totally eliminate it from the lecture, but they will not be on the test. Now, some changes to the criteria that I think are worth knowing is for schizoaffective disorder. For the most part, it's unchanged, but now we consider that a major mood episode, and typically that's major depression, needs to be present for the majority of the disorder's duration once the patient has satisfied the psychotic criteria, or otherwise known as criterion A of schizoaffective disorder, which is the same as criterion A for schizophrenia, so the psychotic features of schizoaffective disorder. For delusional disorder, and this is kind of useful, but it's also kind of confusing to a certain degree, but it probably needed to be done. Delusions no longer have to be non-bizarre. And the reason that that can be helpful for us is because it can be very difficult to differentiate between a bizarre delusion and a non-bizarre delusion. I mean, if I think Tom Cruise is in love with me, that's kind of bizarre. But it's also not out of the realm of possible. So it's also non-bizarre. So you can see how there's sort of that gray area between bizarre and non-bizarre. So the nice thing is for delusional disorder, you can have delusional disorder and also have bizarre delusions. So Tom Cruise being in love with me would certainly be bizarre, but now I can actually have erotomanic delusional disorder with that delusion. I don't think that at all, trust me. Okay, so we do have the introduction of a bizarre type specifier for delusional disorder, but I wouldn't worry about subtypes for the USMLE. Now, that having been said, remember that in order to diagnose delusional disorder, the patient cannot fit the criteria for schizophrenia or schizoaffective disorder. So typically what that means is patients with delusional disorder do not have severe impacts in their daily life where they're unable to hold a job or things like that. Delusional disorder is no longer separated from shared delusional disorder. So we used to have this thing where, like, let's say you're married to somebody with schizophrenia and you ultimately start to develop, or you're married to somebody with delusional disorder and you begin to develop the same delusions. We used to call that a folie à deux, or a shared delusional disorder. Now, if a patient has that, it's just plain old delusional disorder, and that's probably good to consider it that, because these patients are still going to have the same social ramifications as patients with just regular old delusional disorder. That having been said, it's worth recognizing that shared delusional disorder is still sort of a thing, even though we don't classify it as its own thing anymore, and that oftentimes patients who then are separated from the person that has delusional disorder, their delusional disorder will then go away.
Whoops. So, some general principles of psychotic disorders. You're going to want to first get down the difference between hallucinations and delusions. So, hallucinations are a sensory perception. This is something that the patient sees that isn't there. It's something that the patient hears that nobody else can hear. It's something that the patient feels that is not actually stimulating the patient's nerves. Okay, so this is a sensory perception that's not real. This is different from a delusion, which is a different interpretation of reality. So, for instance, a delusion could be I feel like my spouse is cheating on me when there's absolutely no evidence to corroborate that. Or a delusion could be that the FBI is following me, or it could be that an alien planted a chip in my brain. Okay, so it's different from a hallucination, which is actually a sensory experience. This is a delusion is actually a thought or an interpretation. And so we want to know the difference between non-bizarre and bizarre delusion, which is usually pretty easy on the extremes, but there can be some gray area. A bizarre delusion would be something that's entirely unusual, fictitious, like aliens or being implanted with a chip or something of that nature. A non-bizarre delusion is something that's possible, but really is sort of contradictive to what appears to be reality. So that would be the president said my name and it was referring to me in the State of the Union address, or that commercial was speaking directly to me as if it was a one-on-one circumstance. All right, so the difference between non-bizarre and bizarre is that a non-bizarre delusion could actually happen, even though it's clearly not what's happening. Whereas a bizarre delusion is just something that's totally out there. When we see a patient with hallucinations or delusions, the first thing we're going to want to do is make sure they're safe. And then the next thing we're going to want to do is make sure that this is not coming from some kind of drug. Because if it is coming from a drug, then our management is going to be different. So the best way to do this is with a urine tox screen. Now, psychotic disorders, generally men have an earlier onset than women. Men will tend to present in the late adolescent, early adulthood period, whereas women will present in their late 20s or early 30s on average. But this could present at any time. There are some medical conditions that will give psychotic-like symptoms, but they are not psychotic disorders, and the first of which is epilepsy, most prominently temporal lobe epilepsy. If you remember, the auditory cortex is in the temporal lobe, and so auditory delusions can be caused from temporal lobe epilepsy. So that's one thing you're going to want to rule out, and that can be done with an EEG. Okay, that doesn't mean you're not going to treat the patient with antipsychotics if they're posing direct harm to themselves or others, but before you diagnose them with schizophrenia, if you may want to get an EEG first if there are other symptoms of epilepsy. A stroke or TIA, definitely look for in an older patient, hypercholesterolemia, high blood pressure, etc. Encephalitis, if the patient has toxic symptoms, fever, low blood pressure, and then a mass-occupying lesion if the patient has symptoms of a brain tumor or if there was trauma involved. Usually you'll see this in the question stem. And of course, assess safety and hospitalize the patient if they pose a risk to themselves or others. Always err on the side of caution. So there's a few theories of schizophrenia. I put all three of them up here. The most important one, though, is dopamine theory, and that's the idea that there's an increased amount or activity of dopamine, primarily in the basal ganglia, and this is our basis for treatment in schizophrenia. We use antidopaminergic drugs to treat these patients. So there are multiple types of psychotic disorders. The most prominent and most well-known is schizophrenia, and that's when you have these psychotic symptoms that we're going to talk about for more than 6 months. Schizophreniform disorder is the exact same symptoms, it's just the patient has had the symptoms for a shorter period of time. And then a brief psychotic event, even a shorter period of time than schizophreniform disorder. Schizoaffective disorder is a psychotic and mood disorder combined. We'll talk more about that. And then a delusional disorder is a disorder simply of delusions. Really, what these disorders are in general are a disorder of one's ability to interpret reality. So that's something to keep in mind. That's a good way to characterize all psychotic disorders. All right, so some antipsychotic drugs. We're going to go over drugs in greater detail in a different review, but the mainstay for treating any of the psychotic disorders are atypical antipsychotics. So what's atypical versus typical? First of all, what you need to know is all these drugs antagonize dopamine. The typical antipsychotics are the older drugs. So these are like Haldol and prochlorperazine and Pimozide. These are medications that have some major side effects, so we typically don't want to use these if we can avoid it. These drugs can cause extrapyramidal symptoms, which are Parkinsonian-like, it's movement disorders, and they can also acutely cause neuroleptic malignant syndrome, which can be deadly, and that's characterized by fever and muscle rigidity. The atypical antipsychotics are preferred. I put quite a few of those on here. All of these would be good except for clozapine, which we sort of use as a last resort. They all cause weight gain, particularly ziprasidone, which is Zyprexa, causes weight gain pretty significantly. Clozapine, the reason we don't want to go right to clozapine is because it's associated with a decrease in the white blood cell count, and so it can make the patient susceptible to different infections. So schizophrenia is characterized by having two of these symptoms that I put up here, and those are delusions, hallucinations, disorganized speech, very disorganized or catatonic behavior, and negative symptoms, which are affective flattening. That's just where the patient just has a dull demeanor, doesn't really speak much, really isn't there. Avolition, which is where the patient doesn't seek out any kind of activities that they used to seek out, kind of almost a depressive-like symptom. And of course mutism, which is probably the most prominent negative symptom. That's where really the patient just doesn't talk at all. If you have any two of these symptoms or more, and negative symptoms being just one symptom overall, then you have schizophrenia if these symptoms had lasted for 6 months or more. Okay, so if the symptoms have only lasted for a week or 3 months, it's not schizophrenia yet. Okay, this is only if the symptoms have lasted for 6 months or more. And as you can imagine, these symptoms are going to severely impact the patient's daily life, their social life, their occupation, and because it impacts their occupation to such a great degree, there is going to be a downward drift. These are going to be the patients that, they were college students, they had a successful business career, and 3, 4, 5 years later, now they're homeless. So definitely keep in mind that the severity that this impacts the patient's life. There are 5 subtypes of schizophrenia. The most prominent that you're going to see most often is the paranoid type, and these are patients that have delusions of persecution. Somebody's following me, somebody wants to kill me, somebody's after me. Usually these delusions are bizarre. So they may have delusions of UFOs, may have delusions of aliens, and it really impacts their life. They'll have visual hallucinations or auditory hallucinations. Usually auditory hallucinations are more common in schizophrenia. Auditory hallucinations will be very negative, speaking about the patient in a very negative manner. And they can also have delusions of grandeur, which, remember, you will also see in mania, but mania will not have psychotic symptoms like hallucinations and delusions. We had a patient once who claimed to play Division I football and had a law degree and a medical degree, and he was only 25 years old. Obviously, delusions of grandeur. Disorganized schizophrenia has the worst prognosis. These patients come in, they've got disorganized speech, really no association with reality, and they're very childlike, and it's very difficult to maintain an interview with these patients. Catatonic schizophrenia have prominent psychomotor symptoms. A lot of times you'll see them in very fixed positions. They may be in the cafeteria with the other psychiatric patients, and they'll just be sitting there, staring at the wall, not moving. These patients don't talk much, so as you can imagine, it'd be very difficult to interview these patients as well. And they tend to repeat what you say or what you do. That's called echolalia and echopraxia, and that's very highly associated with the catatonic type of schizophrenia. Undifferentiated really doesn't fit into any of these three categories, and the residual type of schizophrenia, they don't have psychotic symptoms, they only have the negative symptoms of schizophrenia. You're not going to see that one too much on the boards, but just be aware that it exists. It's not incredibly important to be able to determine between these 5 types of schizophrenia because we're going to treat these in the same way, but be aware that they exist. So as I mentioned, disorganized schizophrenia has the worst prognosis of the subtypes, and the diagnosis for schizophrenia is clinical. There are imaging studies that you can do in schizophrenia, but it's absolutely not indicated or necessary. It's purely academic. The management for schizophrenia includes atypical antipsychotics. That's the mainstay of treatment in any psychotic disorder, in anybody experiencing active hallucinations or delusions, and regular psychotherapy. These patients need to be monitored and managed because in order for them to live out in the real world, which is our goal of treatment, they need to be monitored. We need to make sure that their antipsychotic drug dosage is at the right level, they're not experiencing drug toxicity, and you're going to want to have a social worker on their case to maximize their potential. So here's what I meant by the imaging, and I want you to pay special attention right here to these ventricles. Okay, notice that this is a schizophrenic twin, and then their well twin. And you would expect that you would have pretty similar appearance of the brain, but these ventricles are much bigger in the schizophrenic twin. So why is that? This schizophrenic twin does not have hydrocephalus. That's not the reasoning behind these big ventricles. The reason that these ventricles are large is because the dopaminergic activity has been increased so much in this schizophrenic twin by the nature of their schizophrenia that really their basal ganglia has essentially been burnt out. And so their ventricles have just been enlarged by brain space being created. So you'll also find a reduction in cortical volume. We don't really see that here too prominently, although the cerebellum might be a little bit smaller in the schizophrenic twin. And then on PET scan, you're going to see a hypoactive frontal lobe and a hyperactive basal ganglia. We'll take a look at that. The monozygotic concordance is 47%, so this is really something that runs in families. So here's the PET scan that I was talking about. This obviously, they're not twins, but you can see there's a little bit less, green is less activity, red is more activity, and then yellow is in between. there's less activity in the frontal lobe. So remember what the frontal lobe is responsible for. It's your executive functioning, which is your higher order thinking. So this is what's going to make you be able to function, as a manager, as something other than a low-level job. This is where your manners are. This is your personality. So obviously this is why schizophrenics have some of the symptoms the way they do. And then the increased activity is right down here in the region of the basal ganglia. So schizophreniform disorder, if you know what schizophrenia is, then you know what schizophreniform disorder is. The only difference is schizophreniform disorder is not having psychotic symptoms for more than 6 months. It's having psychotic symptoms between 1 month and 6 months. So if you're having psychotic symptoms and you've had them for between 1 month to 6 months, then you have schizophreniform disorder. Once you pass 6 months and you're still having psychotic symptoms, regardless of whether they're being treated or not, you have schizophrenia. Okay, so the only difference is the timing. We diagnose and manage this the exact same way, and these patients are given atypical antipsychotics, and of course if they're posing an acute threat to themselves or others, they're going to need acute hospitalization in a psychiatric unit. Not all of these patients go on to schizophrenia. I think I heard once that it was about half of schizophreniform patients go on to schizophrenia. Brief psychotic episode, just kind of on the same continuum. This is patients that have had the same psychotic symptoms that we've been talking about, but for less than 1 month. All right, so this is before you have schizophreniform, and even further before you have schizophrenia. So we treat this the exact same way, atypical antipsychotics. Benzodiazepines can be useful in bringing a patient down from any kind of aggression that they have related to the hallucinations or delusions. And a lot of times brief psychotic episodes precipitate after a stressful event. Now, remember, you can have a maladjustment, an adjustment disorder after a stressful event. How do we know the difference between a brief psychotic episode and an adjustment disorder? Well, an adjustment disorder never has psychotic symptoms. So if the patient is having a stressful event and then they're depressed and they're stressed out and they have psychotic symptoms, that's not an adjustment disorder. That is a brief psychotic episode if it's less than 1 month. If the patient hasn't recovered, obviously after 1 month, then it shifts to schizophreniform disorder. So schizoaffective disorder is a little different. So schizoaffective disorder is a patient that has symptoms of a mood disorder, but they've also got psychotic symptoms at the same time. And now we're going to want to get this down. The schizophrenic symptoms, the psychotic symptoms, have to be present for at least 2 weeks while the patient is not having mood symptoms. Why is this? So let's say we have a patient that meets the criteria for manic depression, for major depression, and they're also having psychotic symptoms, so delusions or hallucinations. And then their major depression clears, and their psychotic symptoms clear. What was this diagnosis? This diagnosis was major depression with psychotic features. Now, in order to diagnose schizoaffective disorder, the patient has to have psychotic symptoms when there's not any mood symptoms present. Okay, so if you have a patient who has major depressive symptoms and they've got psychotic symptoms, and then their major depression clears and they're still having psychotic symptoms, if they've had those psychotic symptoms for 2 weeks without the mood symptoms, then they have schizoaffective disorder. And with everything I said, you can replace major depression with manic episode, with mixed depressive manic episode, with bipolar, anything. Okay, so this is any mood disorder added to psychotic symptoms, and then they have the psychotic symptoms for 2 weeks while they're not having that mood disorder symptoms. Okay? So this is psychotic symptoms without mood symptoms, it's mood symptoms without psychotic symptoms, and it's psychotic symptoms with mood symptoms at the same time. This tends to have a better prognosis than schizophrenia, and we're going to treat the psychotic symptoms first. Think about what's more dangerous for the patient: having delusions and hallucinations or being depressed. Hallucinations can cause you to run off a roof. It can cause you to run into oncoming traffic. We need to treat the psychotic symptoms first. So we give them atypical antipsychotics, and then we treat the mood symptoms. If they meet the criteria for major depression, we're going to give them SSRIs. If they meet the criteria for bipolar disorder or manic episode, we're going to give them mood stabilizers. We'll treat the mood symptoms in the exact same way as we would treat the mood disorder as if it had existed by itself. Okay, so schizoaffective disorder is kind of a mosh between schizophrenia or schizophreniform disorder and any of your mood disorders. Delusional disorder is something entirely different. So remember we talked about delusions. These aren't sensory perceptions. These are thought disorders. These are patients who perceive something that really is not what's going on. And it really is, it's believable. It's not bizarre, but it's for instance, the patient who is absolutely convicted that their spouse is out to murder them, or they're absolutely convinced that they're going to run this humongous business, or they're absolutely convinced that everybody's in love with them, or whichever star on TV is in love with them. So these are non-bizarre delusions, and the key for delusional disorder is that there aren't hallucinations and there's no impairment in function. So these patients have logical thoughts, they're coherent. The only thing that sets them apart is that they have these delusions that just don't make any sense. Any logical person would know that that is not the case. Leonardo DiCaprio is not in love with this, random woman in Minneapolis. It could be, but it's absolutely ridiculous. Okay? So, really, this is kind of where the gray area comes. You have to, yes, some of these things could happen, but you have to use your common sense as a clinician to diagnose this disorder. We treat these with antipsychotics and with psychotherapy. Please remember to keep the culture in mind. If the delusion is an accepted cultural view in that patient's culture, then it's not a delusion. So there are patients in Latin America that may believe that there are different types of treatments for their disorders, or that there's bad spirits inside of them, or various things like that. I hope I'm not offending anybody's culture, but I'm just making an example. You'll see this in Native American cultures and in African cultures and in Asian cultures. Things like this, if it's consistent with their culture, then it's not a delusion. Okay? So keep that in mind. Then all psychotic patients are at increased risk of suicide. So we really need to make sure that these patients are adhering to psychotherapy, and that we're keeping tabs on these patients at least once a month. You might remember this movie, A Beautiful Mind. This is John Nash. As you may know, he suffered from schizophrenia, and he said it's almost as if a demon had passed from one host to another. Obviously, this is a very brilliant man, and he also had schizophrenia. So you're not always going to see schizophrenics in the low socioeconomic statuses or in people that seem retarded. Okay, these are people that could be like you and me. They could be very accomplished people. They could be your neighbor. So you have to not stereotype that these people are going to be your homeless bums on the street, because schizophrenia can come on at any age. It can be in your 30s or 40s, and it can happen to any of us. And it's very, very difficult for families and patients to deal with. All right, so I will see you in the next chapter.